Okay. Welcome back. That's our time, 10:50. I guess people will be joining us as we go along. Just to make sure that I'm not the only one in the room, can you just drop me a message in the chat box to make sure that there are people before I crack on? So if you're here, yep, okay, brilliant. Yes, Isa is here. Okay, yep, thank you. Yep, okay, yep, brilliant. Thank you. Good. Okay, thank you. So at least there are a couple of people. Yep, thank you. So, yeah, thank you. Brilliant. So we will continue. So false assessment. Okay. So false assessment. So how do we look at people who have fallen? What do we do about it? There is this flow chart. This is developed by the NICE. So the NICE is the National Institute of Clinical Excellence. It's a governing body. It's the organization here in the UK that is responsible for setting guidelines. Okay, guidelines for practice. So most of the public hospitals have to follow those guidelines unless if none exist, then they find the best available evidence or justify why not to follow guidelines. So the NICE have given this as a way of looking at patients with falls. So let's start from the beginning. Right on the top, that is the entry point. The blue, the one that is colored in blue. So the first one talks about, it's about the two entry point is about how you possibly can come across the patient, okay, patient with falls, how you can come across them. Earlier on, when we were talking, I think Francisca mentioned about her patient told her that the NEPA took light. So one is that we can come across patient that can present to our healthcare system. So the patient will come to our healthcare system that have falls or falls related injury. This type of patient, the evidence shows that they are more highly likely, 70% chance that the view is poor. Okay, I will try to get. Thank you. Ooh, let's see. I will upload it on the WhatsApp so that we can have it, so that I will not just be talking. Let's see. I can quickly upload it now. Thank you for that feedback. Let's have a look. Or maybe I will let me put it on the chat box here, and I will try to upload it also. I think the participants WhatsApp, or maybe let's see if I put it here. Can somebody put it on the participant WhatsApp, please? Yeah, So hopefully you can open it and view it and download it and expand it. It's just a lot of information that I guess I can't, there's how much I can be able to. So yes, I've put it here. Can you put it on the WhatsApp? Those that people, somebody should transfer it please to the WhatsApp, or we can all use it also from here. Okay, so let's come back. So, okay, it's okay now, Al-Qasim. Okay, brilliant. So it's 70% of those with risks of falls, they are more likely to fall in the next year. They are more likely to fall one or more times in the next year. So when a patient presents with you, that bit is the question of have they fallen within the past 12 months? This is false history. So that's one of the main point for assessment. So if you look at your sub note as a physiotherapy, so the sub note, we are talking about your subjective, objective assessment plan. So taking the history will fall under the subjective bit. So false history, within the last 12 months, one of the questions we asked, how many times have you fallen? Or most false assessment template. And if they've fallen, they will tell you they fall, and then that's a yes. And then we assess the fall severity. So we're talking about I'm looking at the pathway on my right hand side. So it will be also hopefully on your right hand side. So I'm looking at the yes category. We assess the fall severity. And if they answered yes, look at the injury. They have an injury. They have fallen more than twice in a year. So one thing with falls is more than once in a year. So two or more. Then if they've fallen two or more, then we categorize them as high risks of falls. High risks of falls. And once they are in that category, then the goal is to develop a secondary prevention because they are fallers already. So it's to prevent them from having that frequent falling. Because like we said in the beginning, somebody who has fallen, they are more like 70% chance that they will fall again. So it's trying to prevent them without treatment. So secondary prevention and treatment. And it is recommended once they are at high risk of fall for us to consider what we call a multifactorial falls assessment. Okay, multifactorial falls assessment, which we'll talk about it. So looking at different aspects that contributes to fall. In our conversation earlier, we said that there are different aspects that contributes to fall. So you need to look into every single bit of those different aspects that contributes to fall. I will leave the last two parts. We will talk about it in my subsequent slide, the intervention. We're looking at assessment in this section. So those with high risks of fall, you look at different aspects, a comprehensive review of what contributes to their fall. The same patient that presents to our clinic, okay, if we assess them and it's a no, they have not fallen more than twice in a year, they are not frail. Frailty is another thing that we looked at. They've not lie down in the floor for a very long period of time, all those questions. Then if they said no, but it is recommended for us to look at their gait and balance. They talk about gait and balance in pair. We look at their gait and balance, and we will look at those outcome measures also later on. So in the gait and balance, we look at their gait speed because it's a predictor of falls. The slower a person is walking, the high likelihood of them falling. For example, you can use the 10-meter walk test, which is used for what we call community ambulation, to assess the ability of an individual to be able to function in their community very well. Here they talked about anything less than or equal to 0.8 meter per second is at the risk of falls. Or we look at time up and go test. Time up and go test. here the NICE guidelines, the guideline is the anything more than 15 seconds, it's at a high risk of falls. There are the risks of falls. And if we do the assessment and the outcome measure shows that there is a problem with it, is we categorize them as intermediate risks. And the goal is still secondary prevention and to improve on the risk factors, okay? To improve on the risk factors, secondary prevention and to improve on the risk factors. And I will skip the last parts for the intervention. But apart from our patient, which I think is typically that maybe you come across based on the experience, apart from our patient, it is possible for there is what we call opportunistic finding. Maybe it's less likely in Nigeria, but here sometimes there is that annual health risks visits. There is a maybe just by the way they sort of accidentally review your case notes. It's not that you've presented because of falls or falls related issues, but maybe you went in for a different issues and then it was picked in your records and then you are at risk of falls. That also, if you had a 30% chance of falling in the having another fall. So if it is an opportunistic finding, usually the question is the same question, history of falls, how many times have you fallen? Or sometimes they try to be sensitive. If you can ask the questions about frailty, for example, if the fall they've had they been lying down for a long period of time, uh, just to determine where to go next. And if it is a no, then it goes straight to low risks. It's a no, it goes straight to low risks. However, the primary prevention, whereby, remember we talked about healthy aging, whereby they are encouraged, example, to continue to do physical activity, so that or to educate them about falls and fall prevention programs. So there are lots of falls prevention programs. Earlier on, some people talk about community centers, elderly cycles. So you can refer those here in this country, you can refer those patients to those fall prevention center where they don't have to fall before they prevent it. That's falls prevention. So before it happens, primary or secondary anyway. So we can refer them or we can encourage them in our context back home in Nigeria. We can refer them we can encourage them to be active, to take an evening walk or to move around. And I will skip the last part for the intervention. The main thing is it's multifactorial assessment. One thing with falls, especially those with a high risk, it's encouraged for us to have multifactorial assessment, looking at every single bit of aspect that affects them. And we all agree that it's not one thing that contributes to fall. It can be one thing, yes, but there can be more than one thing. And it's important we look into that. So what I will ask is, what do you include or should we include in falls assessment? Okay. What do we include or should we include in falls assessment? So what are the things that you think we should include in falls assessment? I want us to make a bucket list of it. What should we include in falls assessment? Let's make a bucket list of it. Can we put it on the chat box? What should we include in falls assessment? Or you can unmute yourself if you prefer, and then you can share your thoughts. But I want you to help me. What should we or do you include in falls assessment? Okay, age of a patient. Okay, age of a patient. check their proprioceptive flexibility. Okay, thank you. So that's two. I think we can do more. So what should we? Yep. Okay. Balance, figure. Yep. Muscle power, memory. Okay. Outcome measure, time up and go test. Okay. Assess their gaze. That's interesting. Assess their gaze. Wherever the put assess, do you want to expand on when you say gaze? You can type it in the chat box. What the yes, so maybe you're referring to vision. Assess balance. Okay. Physical abnormalities. Okay, that's a very big one. Okay, PCV, gait analysis. Okay, gait analysis. Yeah, just by the way, also maybe I will talk about it later on. Understand some people have a bit of challenges joining, but hopefully everybody is able to join. I will once we finish this, I will sort of quickly summarize this morning's session, what we talked about, just in case for those that have missed the beginning. Okay, fast scale, yep. Okay. Okay. Assess patient home. That's tributes. I think that's one of the so environment basically. Medications, yes. So that's different aspects. Cognitive and behavioral assessment. So yes, behavior. We talked about behavior earlier. Fear of fall itself. Yes. Fear of fall. Yep. Okay. Thank you. These are brilliant suggestions. So is a question I put why and how. So why and how? Why are we looking? Why are we doing this? And then how are we going to do it? So the first one is false history. Remember we talked about false and false history. False history, if we're looking at using our SOAP note, so looking at the subjective assessment, when you are doing your subjective component, you want to establish a picture of the part of how the false itself. Okay, talking about the frequency, the circumstances where it happens, the injuries as a result of fall. So you want to paint a picture of the false history. The time of the day. Earlier on, I still thank you, Francisca. Francisca mentioned patient for the lineage part took light, and so you look at maybe this person might have difficulty in dark situation. What sort of activity are they doing? Because past falls are the strongest predictor of future falls. And understanding the patterns at which these falls happened will help us modify their risks, help us identify possible modifications. Okay, there are things that we can modify and then that will just solve the problem, and there are things that we can't modify. So false history, it's one of the main things it's used in fault. It's in fact that's the main bit for false assessment. The second part is thank you for those that have keep on putting those in the chat box. The second part is the gait, balance, and evaluation. More mobility. Gait, balance, and mobility. So if you're looking at the SOAP note of assessment, if I said false history will fall under the subjective component, where would my gait, balance, and mobility falls under? Anybody wants to help me?
Falls under objective.
Yeah, brilliant. So the gait, balance, and evaluation will fall under the objective. And with the gait, you are looking at walking pattern, you are looking at speed. Earlier on, we said speed. We'll look at that also detail. The speed at which the person is walking. their transition from sitting to standing. When they are walking, how stable they are, or when they are standing, how stable are they? Are they swaying back and forth? Impaired gait or unbalance are direct contributors to fall. Directly, they can contribute to fall. And that's why we use the commonly used is the talk test that we use for assessing falls. The next bit is we look at vision and hearing checks. Now, whilst some of those things can go beyond us where we make referrals, but we ask those questions about vision and hearing. In vision, particularly as a physio, what I will be looking at is I will be looking at what they call depth perception. So by depth perception, I'm looking at, so when you're climbing the stairs, the length of the stairs, sometimes you can, although we also do it, but sometimes you have tendency to misjudge the height of the step and you can trip or you fall. Or when you're going out walking in the environment, there can be uneven surface and you can misjudge the height of the step. Sometimes it's as well a problem with the depth perception. And that can affect you. And simply, the simple things we tend to do is, I can get 2 pens of different color, similar, and then I will just stand in front of a patient. I will put one closer and one far. Okay, and I will ask the patient which one is closer to the person and which one is far away from the person. Now, if the person is able to tell me, most of us will be able to do, but there are patients who will tell you that they are all of the same height, whilst clearly one of the pen or one of my finger is closer to the patient. Now, a patient that will tell you this, then is the question that you know that they have problem with their depth perception. Okay, and you can mitigate this by either educating them or letting them know that they need to take things slowly because they can't judge the height of things, or you can refer them to the ophthalmology or opticians to review their vision. So depth perception. Another thing is the visual field, where we all know that how you assess it is you try to ask the person to fix their eyes right in front of an object. For example, me holding this pen, I can ask the patient to just keep looking straight ahead, and I'll ask them to look straight ahead without moving their eyes. And now I will try to take the pen away from the point of vision and then ask them to keep telling me when they can see it or not. And I keep moving it to the point where if the patient says still they can see it, I tend to wriggle the pen and then and ask them what am I doing with the pen, because sometimes patients, not just to impress you, they will tell you, oh, they can see it while they can't. And then wriggle the pen just to give them an understanding. I ask them whether they can still see it. And if they said no, they can't see it, it tells you that they have a narrow field vision. And they have tendencies of bumping into things, so they need to be aware of that, or injuring themselves because they can't see things, and so the vision is not supporting them to make appropriate adjustment as they walk around. So poor vision, hearing, it reduces, all of them have tendencies to reduce our environmental awareness and the reaction time, thereby increasing the falls risks. People mention about medication. I'm not a medication review. Sometimes it's just the medication the person is on. I know we are caught on sometimes it's just the medication, and it can increase the person's risk of fall. So by just reviewing the medication, then you will find out that it is likely, highly likely that that can be taken care of. Especially psychoactive. Sometimes the cognitive or psychological status. We talked about memory, attention, and the psychological factors here is the fear of falling. So people talk about fear of falling in the chat box a lot. I think people avoidance skill, fear of falling, fear of falling. So it's the psychological factors. Somebody, especially the elderly that have fallen, they will be so afraid that the fear of falling will increase their risk of fall. You can see the patient when for them to walk, it's a problem. And if they're walking, they are so fixated. and they can put themselves at risk, and you as well, because sometimes they will grab you when they are falling as well. It affects their judgment and safety awareness. And because of fear of falling, it can reduce their activity and increases their deconditioning. Okay, it can lead to reduced activity and increased physical deconditioning, because I have fallen. The best way to avoid falling is to just lie on bed. Or I have fallen. The best way to avoid falling is just not to walk around. And that's not good. We all know that that's not good, because that will push them in that cycle of then their functioning will deteriorate. Is finding a way of trying to encourage, trying to support them. And environmental hazards, we have great examples here. The lightning. So all those things that you guys have talked, the lightning, because it affects vision, the floor surfaces, the stairs, the clutter, the bathroom safety, the accessibility, all of them are home/environmental assessment. All are home/environmental assessment. And they are important because most at times it's not in the hospitals or in your clinic the patient falls. They falls in the home, at home, and possibly also in the community outside when they are walking. Excuse me. So modifying those environments can significantly reduce the risk. And I think also somebody mentioned footwear, footwear or foot health. Yeah, coordination can also be assessed. Thank you. Yes, coordination, absolutely yes. Coordination can also be assessed. So foot health and inappropriate footwear can impair their balance. They might have good balance and can impair their balance. And then we talked about the cardiovascular functioning, orthostatic hypertension, dizziness, can make somebody to just fall, really. So if you are falling, so the multifactorial assessment, sometimes a part of our physio is just for us to be aware of all the things that could be affect fall, and we make the appropriate referral to the other healthcare professionals. So just a quick, the strongest predictor of falls, just a summary of that bit, just to highlight, the strongest predictor of falls is falls history. So what it means is that once we establish that history of falls have a picture, it gives us a picture of, they are one of the main assessment that will tell us whether the person will fall next time or not. Followed by the assessment of physical functioning. So the second predictor of falls, second strongest predictor of fall is physical functioning. And by physical functioning, it talks about the coordination that somebody mentioned, the balance, the gait, all of it forms part of the physical function. But I will ask, and please unmute yourself or put it on the chat box. What is the recommendation for falls assessment? What is recommended for falls assessment? I think I've mentioned it earlier on. What is the recommendation for falls assessment? What is recommended? Is it that we should use the falls history, or what is recommended? Anybody wants to? From the last PowerPoint, what do you think is what is the recommendation for falls assessment? Okay, use the falls history. Thank you, Chioma. Anybody has any different view, or what is the recommendation? Follow NICE guideline. Okay, but Chibuze, what does the NICE guideline says? So that's what I'm asking. What is the recommendation? Or based on the PowerPoint that I've mentioned, what is the recommendation, Chibuze? Or anybody? Identified risk factors. Okay, thank you, Mohammed. Outcome measures, Yunusa. Okay. Thank you. What is the recommendation? Is there any evaluation of it? Can we summarize? Anybody wants to summarize it in a single word? So maybe I'll reframe it. What is the recommendation for assessment? Can anybody summarize it in not a single word, maybe 2 or 3 words? Age, okay, 2 or 3 words. Okay, age. Okay, what I want to raise awareness is and mention is all what you've said is true, but the recommendation is, which we talked about, is multifactorial assessment. Everything, yes, make use of. So the recommendation is, it's not in my PowerPoint here. I mentioned about the strongest single predictor of falls is falls history. Whilst it is the strongest predictor of falls, the recommendation is not just to use falls history for falls risk assessment simply because it's the strongest predictor. Neither is it to just use the second physical functioning. So the physical functioning is when you're doing your reasoning, you use your outcome measures to assess the patient in that. Now, the recommendation is to combine everything all together. Thank you, Sunusi. Is to combine everything all together so that it will give you a holistic picture of the person's health. Okay, so taking into account your falls history, taking into account your physical conditioning, reviewing the medication, footwear, everything we talked about all together. Outcome measure, we talked about outcome measures for a lot, so I will also talk specifically about them, but there are lots of them. There are lots of them, outcome measures, and I will share this on the chat, and please, by all means, you can put it on the WhatsApp group. Regarding outcome measures, one site I find extremely useful and helpful and evidence-based is Rehab Measures. Some of you may know or may not know. So it gives you a summary of, so I've put it in the chat box. You can go to this site and have a very good summary of outcome measures. So outcome measures is not only about just using a tool, it's about finding its relevance to use it in your clinic. Why are you using it? What does the evidence says in using it? How to use it appropriately? So this site will help you. If you're looking for an outcome measure, you can go in there and see those ones that are validated and out there in the public. You can find it, hopefully most of them, especially physio related, on this side. Although we know that it's not necessarily we have to always use outcome measures. You can use functional assessment. You just to have a baseline and post baseline. But the outcome measure is a standardized tool that has proven to record the changes over time. So that's why we are highly encouraged to use it. So for falls, there are 3, well, a lot of them exist, but there are 3 main outcome measures that that are recommended, or that I would say we should always consider. One is the talk test or the time up and go test. Just a quick one, just so that I will not be assuming how many people. So the second one, and I will talk about, is the back balance skills. The third one is the functional reach test. Okay. So in the chat box, if I want as many people as possible, if or not possibly all of you, those that have used all the 3 before or are aware of all the 3 before in their clinic, not necessarily for falls, but just generally in your clinic, you should put the number 3 in the chat box. Those that are used, or maybe those, so if you use the 3, can you put all the 3, just put talk, BBS and FRT. If you used 2, just put the number 2, put the 2 in the chat box. TUC and TUG and BB. If you use only one, then you just only mention one, or if you have not used one, that's fine. You can leave it blank, so that I will know how much detail we can go in. Okay. Okay. Brilliant. I think most people have used all three. Well, so far the people that responded. Okay, so three. Okay. Okay, three. Okay. 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 So others have used one. Okay. Three. Okay. Okay. So I guess that makes my work super easy. Although not every okay one. Okay. Or maybe not. Okay. True. Okay. Talk on Friday. Okay. Thank you. Okay. So maybe I will, those that have used three, you're going to help me run through this slide. So let's start with time up and go test. Can I have a volunteer for those that have used three to talk us through how they have applied the time up and go test in their clinic, and why did they use it? What are they looking for? What type of patient they use it for? And what sort of outcome interpretation? So that's what I mean they are looking for. So anybody wants to go first? Those that have used the three outcome measures. Any volunteer wants to talk us through?
Good morning, everybody.
Yeah, good morning, Chioma.
So for the talk test,
Yeah.
you put a seat at one end and measure 3 meters from that chair to
Yeah.
maybe over or to one end, another end, 3
Okay.
meters. Then
Okay.
you ask the patient to, as with your timer, when you say go, you should stand up from the chair and move
Yep.
to that point and come back to the chair. So you calculate how many seconds it took
Yep.
the patient to get back to the seat and sit down. Thank
Okay.
you.
Okay. I don't know. You can answer or I can leave it for that one. So why the talk test, when you use in your clinic, what are you trying to assess?
The gate speed and probably the balance.
Okay. And what is there a number you're looking for, or you just looking at it generally? Is there a cutoff mark you're looking for, or you just looking at
Yeah,
it?
there's an average seconds
Okay.
to take to get there. Like I think between 7 and I don't have the numbers. 12
That's fine.
seconds or
That's
something.
fine. That's fine.
Yes, sir.
That's fine. And for your patient, just the last one, what sort of condition is it that you're looking out for, the person that you apply this talk test for?
The person is 92 years.
Oh, okay.
So they're
And
just doing, when we have such age or elderly people, we just do it generally to be sure everything is fine.
wow, that's
So
good. Which setting is that? That's good.
it's a private clinic in Lagos.
Oh, okay. Yeah, private clinics. Okay.
And it is
That's good.
also used among amputees to assess either balance, the gait speeds, and fall risks, most especially when they are given prosthetic limbs.
Okay.
So it's part of the assessments that we
Have you
usually do.
used it? Okay. You use it in your clinic?
Yes.
Okay. Yeah. Thank you. And do you remember the interpretation that you're looking out for? You remember, Suleiman? So so when you look at them after they do it, what does it tell you? You remember what you're looking out for? Okay, thank you. So talk test. Absolutely, yes. I think Chioma and Suleiman, they've mentioned it.
Okay, you are
yes.
looking out to see if the person is have high risk of fall.
Okay, good. If the person is have high risk of falls. And there are things that we look out for. So Chioma have explained the process and procedure, and you can find information online out there. I'm not going to spend much time on it. But it's actually a good outcome measures to use to screen for high risk of falls. Example, the private clinic in Lagos. It's I think it's a good practice to screen elderly, especially at that age, using those outcome measures. There are a lot of things to look out, but mobility, balance, functional movement generally, because when somebody sitting to standing, that's transition. Okay, that's transfer from sitting to standing. That's functional movement. So you're looking at that transition, functional movement, sitting to standing. Okay, but also you're looking at somebody is walking. That's mobility. You are looking at walking. You're seeing the quality of their walking, are they swaying, and then the balance, because there is that dynamic as well as static balance. When they stand up, they need to balance themselves and walk. So it gives you a lot of information, the outcome measures, and it is being validated. So you can look at the sites that I've put in. You can look at the validation population you can use. That doesn't mean you cannot apply it to your own context. That is where you will. Thank you, Suleiman. That is where you will see. So that's where the evidence comes, which we'll talk about it later in the afternoon. The fact that an outcome measure has been validated in a specific patient population, while that is the recommendation, you as a clinician, you can make a judgment for your patient on whether to apply it on the other context or not. So for the talk test, it's risk of falls, but there are different way of categorizing it. Good. Yes, thank you. Okay, so maybe your numbers, now the numbers varies, but I put my numbers, it may be slightly varied from yours, but the numbers varies, Suleiman. Anything less than 12 seconds is considered, so the longer you take to walk the distance, the more risks you are. We talked about gait speed earlier on. But also, it's not only the numbers, it's the observation of the clinician in the quality and things like that. Anything between 12 to 15 seconds is moderate. Anything more than 15 seconds is high risk, okay? But I understand, especially if you are talking about amputee, for example, maybe you can have modifications. If you look at patient situation, you can have modification. There is nothing wrong with it. You can look at it in your context. Thank you. Let's move to the next one, back balance scale. I know there are a couple of people that have used back balance scales before. Anybody wants to, the same justice that Chioma and Suleiman have done for us, anybody wants to do the same justice for us? Ooh, that's a good score, 92, 7 seconds. Wow, that's good health. Thank you for that. So anybody wants to talk us through about back balance scale? So in your clinic, why do you use it for? What are you looking for? What does the measure, what does it assess, and any interpretation of it? Back balance scale. Amongst anybody any volunteer, people that mentioned about that they've used 3. Somebody different this time around. Somebody different this time around. Somebody different. Looking out for volunteers, please.
Back
Don't leave
balance,
me. Yes, carry on.
back balance scale, as the name implies, is used in assessment of balance and also for risks among individuals that have either neurological or musculoskeletal conditions. And it consists of 14 items, which evaluate various aspects such as sitting and standing, transfers, reaching and leaning, turning, and then standing on one leg. So while using back balance scale, there are certain things you might need, like chairs, armless chair, and then the chairs with the armrest, and so on.
Okay.
It
And
assesses balance and fall risks.
okay, but can we go back a bit? So when you said it assesses balance and fall, so let's talk about the balance. Balance contributor of fall. So when you talk about balance, is there any part, do you want to expand, or anybody within the conversation wants to expand by, when you say balance, what do you mean by balance? So is there any particular type of balance that it assesses? So balance is a broad, big term. Anything in detail that, yeah.
It assesses dynamic balance.
Okay, so Abdul talk about static, you said dynamic. So there are two ideas. So Suleiman, you said static, dynamic, Abdul says static. So which one is which? Is it one or the other or the both?
Well, it's been a while I use back balance scale, but
no, that's fine. It's just to just generate. Yeah, carry on.
Yeah, but from my understanding, dynamic and that of static balance usually is assessed with patients standing erect at the beginning with eyes open, arms by the side, and then you observe whether the patient's swaying whether side to side or forward and backward while paying attention, and then progress to eyes closed. All this is used in assessing static, but if activity is included in assessment of balance, it's usually dynamic balance that you're assessing. And in back balance scale, most of the items are assessing balance with activity.
Okay, but is there any component that assess balance without activity?
They are the first aspects.
Okay.
So it combines both.
Okay, that's why we are. Okay, thank you for arriving at that. So I guess, so thank you. I think that's a well reasoning. Thank you, Suleiman. That I like the line of thought. And I think people also in the chat box have been putting information. They mentioned about both. It assesses both. Janada and Ahmad mentioned about it assesses both. So yes, it assesses both static and dynamic, and absolutely Suleiman have laid the thinking and reasoning behind it. The static balance is where you are stationary. The dynamic balance is when there are activities involved. So the back balance scale starts from the static balance and move towards to the dynamic aspect. And because it's challenging, so it's progressive in nature. Okay, it's progressive in nature. When you start from the basics, and then if you've been able to achieve this, you move to the next. If you'll be able to achieve this, it needs to the next, up to the challenging aspect. I'm not going to talk about balance because balance can take us a whole day to talk about balance, because even in the dynamic balance, there are also different components. But that's not what we're looking at, okay, today. But if you are interested, you can go ahead and explore that. So the dynamic balance, we also have different subcategories. So that's the back balance, static and dynamic. They are all both important in falls risk assessment or falls. Our patients are walking, that's dynamic balance. When you're walking, they have to maintain themselves. They have to be able to balance themselves whilst walking, not only in the dynamic state. Now, coming back to still those people that have mentioned about their ability, they've assessed both. Do you remember the scoring of it? What sort of numbers we're looking at? Anybody? Scoring of it, the scoring of the back balance. The scoring of it. Anybody remember the scoring of it? Or the interpretation of it? Any volunteers?
I think someone has put it in the chat.
Okay. Oh, yes. Okay. So that's, maybe let's explore that a bit. So the person put 0 to 4, total of 46. So I guess the 0 to 4. Yeah. Carry on, Suleiman.
No, the scoring is each of the 14 items is scored from 0 to 4.
Yeah.
0 meaning unable to perform the task.
Yeah.
Then 1 to 3 performs the task with either assistance or modification.
Yeah.
And then the 4 score means he performs it independently and then safely.
Yeah.
So the maximum total score is usually 56. And the interpretation is that a person scoring 56 has excellent balance.
Yeah.
Well, though there's difference in literature.
Okay. What do you mean
A
by that?
person scoring between 0 to 20 means poor balance. That's high fall risks. That's the interpretation. Then 21 to 40 is fair balance. With moderate fall risks. And then 41 to 55 is good balance. That's low fall risks. When the 56 is the excellent balance.
Okay. So when you say there are different, there is literature, is it with the scoring cutoff marks that there is debate in the literature or something else?
No, it's like, sometimes the, what is it called? The outcome measures, the interpretation. It's like some clinics, when you go there, when you give them the scoring you have with the scale, they'll say, no, this is not what they were taught, even though without evidence, they will argue. So that was why I said that.
Okay. So, yeah, thank you so much, Leman. So, agreed. Absolutely. The back balance scale is an outcome measure for dynamic and static balance. It starts from the static, goes to the dynamic. These are two important components of balance that, as clinicians, you should access when you're seeing a patient with balance issues. But like I said, today is not balance rehabilitation. Maybe we'll talk about balance rehabilitation sometimes on a different things. It's one of the areas I'm more interested in. But also dynamic balance, there are different components of dynamic balance. Well laid out, 0 to 4, 4 being the maximum, 56. There are scoring for it, 46, 41 to 56 independent mobility. Sometimes there is a cutoff point of 44. Now, yes, there may be debate on the literature, but I think this is one of the objective markers that we use. Here certainly is back balance as a physio. I don't think you will miss that out if you are working in the community. You should know back balance in the fingertips here. If you're going to work as a physio, especially in the community or in areas where you see persons with balance challenges. Time up and go test, yes. And another advantage of the back balance for those that are looking at it, I will recommend is it has the same activity that you will use for assessment. You can use it for treatments. Easy. You convert the challenges that the patient cannot be able to attend into treatments by modifying and lowering it in a safe environment till the point where they can be able to do it. If it is sit to stand without support, you can increase the chair height and then allow them to do sit to stand till when they can do it. If they can't stand with the legs closed and everything, you modify it and they can do it. And one of the challenge earlier on today, I mentioned that we will have a challenge today, and my plan is we will try to have this challenge before we go for the lunch break. And one of the challenge might be part of the back balance bit. And whoever is the first person to win the challenge will have their full refund of the CPD fees. I will refund them their money for CPD. So just to mention, which we talked about, the back balance scheme. Yeah, thank you. So let's move to the next bit, the functional reach test. The functional reach test is pretty much the same. You can use it to assess balance. This also is interesting, false risks as well as balance, because you can go and read about the implementation and things like that. As the picture shows, it's just stretching out and then finding you can draw a 25 centimeter less than an A4 paper is, I think, is 30 or so. So just 5 centimeter off an A4 paper. And from that point, you measure the 25, and then the person try to reach as far as possible. It challenges your balance because it takes you away from the base of support. Okay, it takes you away outside your base of support, and it's about your ability to be stable with displacement, as well as to recover back to your base of support. Okay, which is an important component of balance. So it assesses the stability, the functional reach test. It assesses your stability and balance during the forward reach. And the scoring is on the screen. Low risk, and if you can be able to do the full 25 centimeter, brilliant. But if not, then it categorizes your risks. The next bit is so that's the summary. Balance. Assessment generally. We talked about assessment. Assessment is multifactorial, looking at different components. Start looking at vision, physical functioning, outcome measures, medication review, footwear, all those bits. Then the next part is the intervention. I'm coming back to the nice guideline flow chart that I shared early. For those that are joining us, I shared it in the chat box, and I believe that has been circulated, although I didn't confirm it, in the WhatsApp group. So false intervention. So the recommendation, earlier on we talked about, coming back to the picture, earlier on we talked about there are 2 points at which patients expectedly, based on the flow chart, that will come in contact. One is that they have fallen and they come to us, okay? Or maybe they are worried about falling. The second one is the incidental findings, or whereby we do a normal health review and then we come across patients who have problems with falls, and then we review them. I think Chioma gave us an example. They do a normal routine review for individuals who are at that certain age, which is good practice. So whichever point at which they come, if we are taking at the point where they have a fall, if you go all the way, we've already discussed the first 3 stages. So when a person is at a high risk of falls, so high risk of falls is at my right-hand side. For those that are here, probably will be able to know about those that are joining. So it at my right-hand side. One is recommended that we do multifactorial falls risk assessment, but also it is recommended we have a individualized, tailored intervention for those patients. What does it look like? That's another areas we're going to be looking at. Okay, and then you follow up that. We follow up that in the next 30 to 60 minutes. I think there is a very good, important question that was, well, not question, comment, and I'll come back to that because I absolutely agree. Then the next part is the if somebody is at the intermediate risk or low risk, we tailored the exercise on balance, gait, and strength. And that's where the physio comes in. They will refer you, and we educate patients on falls prevention. So both intermediate and high risk, it's important for tailored intervention as well as possibly education as well. Sorry. And then the low risks, we can educate the patient on false risks and advise them actively on physical activity and exercises, which we talked about earlier. We talked about our role in physical activity or exercise. So the question is, what do you include or should include in the intervention? So when looking at the intervention, and you can put a bit of details in it. What do you include or should include in the intervention? Just like we did for assessment, I want us to make a list. But before we go on making a list, there was a comment on the chat box about Abdul Rahman. I absolutely agree with you. You said the challenge is back balance scale is timing. Now, before I give you my answer and how I applied it, and I think for me, I find a way out, maybe not. Just I will put it back to the audience. For those that are use it, or what do you think? So the challenge, let's say we have a challenge of timing or not. How do you go around it? How do you go around if those that have implemented bank balance scale in their clinic, how do you go around the challenge of timing? Because it's 56 questionnaire, that is a lot of questionnaire. Four responses that you have to go. So it's 56 times 4, that's in excess of 200. In here in UK, I guess you are time bound on how much you can see patients, so you need to finish everything and continue and move on. So those that have used it in Nigeria, can you please advise us? How do you go around the timing of challenge in back balance scale? Anybody wants to give us in, share their, okay, there is a modify form, okay? Isama talks about there is a modify form. But even with the modify, okay, that's good. So uses the modify form, okay? Anybody else that wants to tell us more about how do they go around it? Those that use it, how do you find it? Do you find it challenges? How do you go about it or not? Yes, Yunusa Muhammad Usman.
Yes, sir.
Yeah.
Like actually, we used to start with the highest number, that is score of 4.
Okay.
Because if the patient can perform the 4, so no need to assess the rest. He can definitely do 3, 2, and 1. Just we go like that.
Yep.
But unless if he can't do it, so we have to follow all the four tests that we carry out. That's how mostly we minimize the timing.
Agree with you, Yunusa. Thank you. And that's one of the things I actually do. Yes, absolutely. Yes. Anybody has anything they want to add? So yes, let's crack on. One of the ways to just thank you, Abdurrahman, for raising it. But one of the ways also, which maybe you probably also have find ways to do it, is what Unisa says. So there are 5 questions from 0 to 4. So instead of you going from the 0 and going all the way, you just go to the highest score. And then if they can do, you move to the next bit. Another way is you skip, because somebody who is practically on their feet, you don't have to worry about sit to stand. If you think that they can be able to do that, so you skip and you start from the challenging aspect, and then you progress going forward to the point where they can't do it, and then you take your score. That's another way to look at it. And really, outcome measures are tools in our hands that are meant to help us. Okay, we should not. So we need to consider the practicalities of it, and that's one of the research challenges of having a beautifully crafted piece of evidence, and then it's of no relevance or utility, which we will look at in the afternoon in clinical application. So sometimes you can decide even to just keep it and then start from the highest bit. Okay. And then you take it off from there. I think that's one of the challenge. Maybe less likely. Sometimes people start and stop and then continue at a later stage. You don't have to finish everything. But I agree with you. Now let's come back to my slides. Let's make a list. In terms of intervention, based on what we said, we will assess. Based on what we said is the problem. What should we include, or do you include in your intervention in falls? You can put it in the chat box, or you can unmute yourself. Any contributors, volunteers? This is the most exciting part. So I will expect some people to be typing, flying with chatting, typing in the chat box. What should we include or you include?
All right. Good morning, everyone.
Yeah, it's still morning, Tuesday.
Can I contribute?
Yes.
All right. In management of fall, you normally involve the multidisciplinary team. It's not something you manage alone. So it's something you involve the podiatrist, you involve the ophthalmologist, because the patient presents with a lot of things, like looking at the NICE guideline.
Yeah.
Or the multifactorial fall risk assessment, a whole lot of things could lead or predispose someone to fall. So it's not something you manage alone. It's something you involve all the other team, all the MDT teams to join you in the management of the condition. So you can also involve the occupational therapist who go home to ensure that the home is covered, modifications that needs to be done, grab rails, maybe slippery, uneven floor, a whole lot of things. So it's a disciplinary team approach. That's the best form of management. Thank you.
Thank you so much, Chibuze. But if you will stay with me now, that doesn't mean you must answer my bit, but I just want to explore your line of thought a bit more. I agree with you. Absolutely. It's multidisciplinary. That is the first approach. You talk about the podiatric because earlier on we talked about footwear affects falls. So it needs to look at footwear. You talked about occupational or health or what occupational therapies. We talked about home environment. You talked about vision. We talked about ophthalmologists. That are brilliant. So that's the first thing, multifactorial bit. But apart from multifactorial bit, so that one is multifactorial bit. Is there, looking at it specifically, let's say for physio, what are those things that you think we should look at? Okay, somebody have started putting a chat box, but if you want to talk about any word like the same thing you discussed about your multifactorial bit, anything we can look at as a physio, Chibuze.
All right, as a physiotherapist, especially managing a fall risk or a patient with a fall, looking at the NICE guideline, what they mention about the age factor. Okay. Especially once a patient reach 60 years and above, the person they are normally predisposed to fall because of the weakness of the loss of muscle mass due to age-related factor. Okay. So I think that we should also be looking at that one, looking at how to train this patient to ensure that this patient, the lower limb are stronger, carry out a whole lot of assessments to ascertain the cause of the fall and how best to manage that.
Okay. Thank you so much. Yeah. But just to mention, 60 is not old person in UK. So don't tell somebody 60 that is still good to go 60. But anyway, that's just saying, but 60 is still good to go. Especially if they are well looked after. 60 people, they are still bouncing.
65 years, looking at the NICE guideline, it says 5 years and above. That is when there is normally loss of muscle mass, especially in the lower limb, that predisposes someone to fall. Sorry about that. It's 65, not 60.
No, that's fine.
Thank you.
Yes, thank you. So I think there are people, Abdul Shakur and Alheri, and they've been putting ideas which are great. So as a physio, what we're looking at is there are different things, what they call multi-component. So that's what I want us to look at. So one, there is the multifactorial or multidisciplinary, where you look at different healthcare professionals. And then there is another part where you looked at multifactorial or multi-component, whereby as a physio, you look at different aspects. Okay. Earlier on, we talked about gait. So gait can affect falls. How? Let's say lack of flexibility of at the Achilles tendon or tibialis anterior. it affects the person's ability to react to balance when they trip. So you can look at your flexibility exercises. We talked about balance. We looked at outcome measures. You can work on their balance. So different components that contributes to balance is what you should look at. Gait, balance, functional ability or transfers, coordination. And if we look at back to my flow chart, we said the person with the high risk of falls, if you go all the way down, they mentioned about individualized tailored intervention. And the reason is because once you identify those things that contributed their balance, generally, yes, you will refer to the multifactorial different disciplinary people. But as a physio, you need to come up with exercise. Exercise like that, like just a sheet of paper, oh, exercise is good, but you need to be specific. Are you targeting the balance? That is the problem. Or are you targeting the coordination? That is the problem. Or are you targeting the strength? That is the problem. So you need to probably identify what is the problem, and then your intervention should address the problem. By merely just asking the person to just do some activity or going for general physical activity is great, it's excellent, and everybody should be doing it. But for somebody with high risk of falls, you need to be specific on the factors that predisposes them to falls, address them, and where possible, or come up with compensatory strategies. So also for somebody with medium, moderate risk of falls, and also includes education for that bit. So yes, thank you so much for the contribution. One we talked about is the multifactorial. The second bit is the multi-component physio-specific multifactorial, looking at all the MDT team. There are a lot of successes in terms of intervention wise, a lot of research out there on falls intervention wise. One of the main one is the Otago exercise program. If there is anything, one of the things that you can take away from today is, I know some of you maybe have been using it, but Otago exercise program is one of the good things that you can go and pick and use in your clinic, where they are looking at basically strength and balance. Okay, you can modify it, but Otago exercise program is one of the things you can look at, and you can find that out in the information online, or maybe I can make a list at the end and I can share that with the whole group of all the things we've been mentioning. One, the Otago, and two, possibly the outcome measure, but you can find those online. So, ideas to impact. Earlier on, for those that are joining us, or maybe before we do the yeah, I will talk about this later. For those that are joining us, when I started today, one of the things I said is I will refund whoever that has been able to do the challenge. I will refund their fees by 100, the full 3,500 CPD fees. Okay, so the challenge is, we are talking about balance. One of the things is balance, but we are talking about false risks. One of the things is balance assessment, balance intervention. There is what we call dual taxing exercise or balance exercises, whereby the person uses two different things at the same times. One is you are challenging your balance system as well as your cognitive system, and to a certain extent your somatosensory system. So three systems that contribute to balance. The somatosensory system, talking about your muscles and information you received. You talk about your memory, your cognition, and the vestibular rather. Yeah. So if what I need is the evidence that the person, whoever is going to do it, and I will encourage, we are all going to do it. Yeah, we are all going to do it. We are almost getting to lunchtime. What I want us to is we're going to stand up. We stand on one leg. Okay, we stand on one leg. You close your eyes. Okay, so whilst you're standing, you close your eyes. And then once you're closing your eyes, you count from 100 in threes backwards. How do you do that? You count from, let's say, 100. The next 100 is 97. The next bit is 94. The next bit is 91. So you do that as quickly as you can. Okay. So you count from 100 backward and you do that as quickly as you can. So that is the challenge that I have for us today. And whoever that is able to do that quickly, I'm aware of the technicalities. If to say it's a face-to-face training, it will be much easier for me. But since it's online, so there are two ways I will like to approach this. One is we do it online, but again, if I'm not able to find a winner, I will give from now till probably tomorrow, 24. Whoever has you can record the video and then forward it to the organizers, the CSP organizers. Whoever has the fastest time, they do it and do it accurately, and the people that have sent their video quicker, they are the ones that will sort of get their full refund. But now I want us to try this, all of us, okay, as much as we can. Okay. Can we all be on our feet? Let's have a practice session. Yeah. I don't think I'm able to do it anyway, but let's have a go. So let's have a practice session. I know we've been sitting for a long time. So let's have a practice session. Okay, and we all be on our feet. Okay, that's good. So I guess we have all on our feet. We'll have a practice session, and then it will be, I will now turn it over to whoever will first of all start with the video here. Okay. While standing on our feet, can you stand on one leg? I'm actually standing on one leg. I guess you want to see the evidence, right? Okay, the floor type have not been discussed. I will come back to you, Jamilu. We'll talk about more when you said about the floor type. So let's stand on one leg. Okay, standing on one leg. Okay. Make sure you are, just to advise, make sure that if you have problems with your balance, please don't close your eyes. Don't stand on one leg. If you have any injuries, it's not easy, Mubarak. That's true. Stand on one leg. Can you stand on one leg? Okay. Please don't do this if you have problem with your balance. If you are swaying, if you are having problem even by standing on one leg, please don't close your eyes. But if you don't have any problems, the next thing I want you is close your eyes. Okay. Close your eyes, and now you start counting from 100. Okay. From 100. 97, 93. Yep. Okay. Okay. I can see we have a couple of I think we have Chioma in the call. So what I want to do now is everybody can keep practicing, but I'm going to have probably give 2 or 3 people who will, let's see if anybody can be able to meet up with that 100. Okay. So who wants to take let's start from here. Let's see if we can. I think we still have a bit of time. I can see Chioma is already cracking on, but there is no evidence that we will know won't fatigue of the stance leg affect the overall result. We can do it with support now. Okay, so I can see Yunus is doing it. Can we start? Let's have a setup. So that's a good research question. So can we have a volunteer who want to start for us? Is it Chioma, Yunus? You want to unmute yourself and count for us? Let's see who will reach to 100. Yep.
Can someone count? It's difficult to count.
Okay,
and stay
that's
there.
fine. Whoever I need 3 people. So Chioma, Yunus, who wants to join the train again? And
I want to join.
Yeah, join. Whoever wants to join, join. Yep.
I can join.
Yes, join. Yep. Okay, I will. When you are ready, are you all ready?
Yes.
Yes, can we?
Okay. Wait first. Is Abdul Bagi here? Is anybody of the NSP Gombe State chapter? Any officials of the Gombe State chapter are here? Can you please take note of the winner? We want to get the winner, and then whoever is the winner, please you. Okay, so we are going to start now. Are you ready?
Yes.
Yes.
Ready, set,
Yeah.
okay, go.
197, 94, 91, 88, 85, 87, 90, 70, 80, 87, 84, 91, 88, 5, 2, 49, 40, 42, 43, 30, 27, 40, 30, 18, 12, 9, 8, 3, 1. I'm done.
Well done. I can see Yunusa is still on it. Well done, Chioma. Well done, Yunusa.
I'm done.
Well done, Esther. I think I can see that you're trying to follow. When the Unwachuku Inkechi, yeah. Thank you. So some people are saying it's easy, it's difficult. I guess we can start from there. Is it difficult or easy?
It's not that difficult.
Very hard.
It's very easy.
Not that difficult.
Very easy.
Okay, I hear you. If your eyes are open. I guess that's another challenge for us. We can try to use that and see if we can improve on ourselves, on our balance. It's not easy. Absolutely not.
It's not.
No, it's not.
Now, aging now, we're also children. 56 to 60.
Are you serious? Congratulations. Well done, ma.
56.
Yeah, the eyes component. Okay. Well, just to talk about this activity we've done before I move on to my next slide. In terms of how it affects your balance and everything. So first of all is when you're standing on 2 legs, you have a very good base of support and you can be able to support yourself. So base of support is important contributor to balance and as well as falls. Once you challenge the base of support in whatever shape or form, it's become difficult on your musculoskeletal system, everything, but particularly your musculoskeletal system has to work harder to balance that challenge. Okay, so standing on one leg, you are challenging the musculoskeletal system or the somatosensory system of balance. That's one. The second one is closing eyes. So vision gives you information, sensory information to give you sensory information about your awareness, but also contributes to your balance because it gives information to your muscles and space and everything. So when you close your eyes, now you are only relying on your vestibular system, cognitive system as well, to maintain you and some proprioception in your legs to get your balance. So it's difficult for you is two things. But when you start counting backwards, you are taking away your cognition. Now, imagine those elderly people. Cognition maybe is not one of the things we appreciate a lot. If they have problems with their cognition, that's how it will affect them. So immediately you started counting, you lose the concentration on your trying to balance yourself, your eyes is not there, and then you lose your balance. And that's how it affects them. And when you're doing your rehabilitation, and we talked about it earlier on, it's important you look at what contributes to their balance and work on it. Sometimes it's not only about our physical exercises, it's also about the cognitive loading, what we call cognitive loading. I will look at that in our research impact later on in the afternoon. It's about your cognitive loading, how you challenge them cognitively. Also, with the dual taxing, you don't maintain your balance in isolation. Earlier on, we talked about balance being static, being dynamic, dynamic being when you have an activity. Most of the times, the function we do requires dynamic balance. So that's why important when you add that cognitive loading, ability of a person to count backward or do other things while maintaining their balance, it's important in supporting them in function or in translation to function. So whenever you are working with your patient, it's important you think about how will they function in the society by adding that extra component of it. But thank you so much with regards to the challenge of the video. And I still maintain I can't see somebody who has completed the one leg stance, eyes closed, counting backwards in 100 as quickly as possible. I try to check the videos. I see some people trying to reach out for their hand on the wall. I see people, so it's difficult. But my offer still stands. If anybody can prove, either record themselves doing that within that bit, please email it to send it to organizers of the CSP 24 hours. So basically from now till tomorrow, if you can prove that and do that, whoever is the first person and the fastest person, you will receive the full refund of the fees of the CPD for one person only. So talking about interventions, the NICE guideline is what we consider, but again, all of us, what we'll be looking at in the afternoon is how we can use the intervention. It doesn't have to be NICE guideline really, but there is strong evidence that exercise-based programs are most important component of preventing falls or falls prevention. So most of the falls prevention activities or falls prevention programs, we looked at Otago as an example, but most falls prevention program focuses on balance, strength, coordination, and functional tasks. So everything you can do for your client, for your patient, to make them improve their balance, strength, coordination, and functional tasks. And for balance, it's about what we do, for example, standing on one leg. And for those that probably have not used back balance scale, standing on one leg is one of the highest activity you will do on back balance scale. Is the 14th question you will do. And that is when I said you can use back balance scale and use it for your treatment. This is one of the things. So standing on one leg. And if standing on one leg is easy, you can add it with eyes closed. If eyes closed is easy, you can add it with counting backwards. But that is not part of back balance scale. And that maybe will take me to just a bit of side comment. With those outcome measures, and some of us may know as well, there is what we call ceiling effect as well as flooring effect. So they only detect changes within the parameters they were set on. While back balance scale is brilliant, there are other outcome measures. Some of our patients will not be able to do back balance scale. And that is why you need to find the appropriate outcome measures for your patient. And you find an outcome measures that have a lower, maybe because lower ceiling effect that is not as challenging as back balance scale. Or maybe there is, for athletes, for example, back balance scale is not used for healthy adult or athletes because it has a ceiling effect. It cannot detect any changes beyond that one leg stance. But today in the class, I asked you guys to stand on one leg, to close your eyes, and then to count backward, which is very difficult. It is not part of the back balance scale component. So it's possible for you to get 56 out of 56 in the back balance scale, and still your balance, of course, it depends on the high demand activity. We talked about environment. It's still not optimal depending on the activities you want to do. And then that's where different outcome measures will come into place. For example, high math. So, but the intervention is balance, strength, coordination, functional exercises. The other multi-component is the home hazards assessments. We talked about it. In Nigerian situation, I guess we physios, we can also double as the occupational therapist. It doesn't, because we have the very limited availability of OTs. And then the medication review, drugs can affect person's balance. And that's why sometimes you can feel dizzy, you can fall, you lose your sense of orientation when you have certain drugs. Vision, where you see the ophthalmologists, opticians to remove cataract, vitamin D, and other psychological factors. Fear of falling, and I have a lot of experience on this. Fear of falling, patients' fear of falling, no matter whether they have a good strength, balance, coordination, simply because of fear of falling, patients can have a difficulty in them participating in their day-to-day activities. And they can also increases them having a falls again. Sometimes it's not the physical functioning, it's the fear of falling. So, intervention summary. We have multifactorial interventions and we have multi-component intervention. The multifactorial intervention is looking at all other MDT teams that I think is it Chibueze that mentioned earlier on. But the multi-component intervention is what our bread and butter as physios, that we're looking at balance, coordination, functional tasks, strength. Exercise, of course, is the obvious choice for balance prevention because impaired strength and balance, they are the greatest increased risks of falls. I think there is a bit of chat in the comment in the chat box. Yes, I agree with you, AAA1. Seniors cannot do that. My stand limb nearly collapsed. Please don't try to do that. Yeah, it will. So that we need to tone it. This is a high level because I believe most of us are hopefully fit and healthy. Seniors cannot do this type of exercises. All you need to do is look at very simple exercises. Otago exercise program have simple basic exercises for the seniors. It can be marching on the spot. It can be even single leg raises. It can be just walking sideways, backward and backward. It can be walking and counting. There are lots of examples. For the interest of times, maybe when we have time later in the day, around 4 or 5, I can revisit that in terms of, I can give ideas for the interventions for different categories. But for now, I will leave it at that. But yes, I agree. So to wrap up, what I want to say, and the key message is, we need to be systematic when you're doing the assessment. Falls, we looked at healthy aging. Healthy aging, we have the aging part, we have the healthy aging part. The healthy aging part, it's about investment in the future where you participate in physical activity exercise to maintain your functional reserve so that when it's been challenged, you can still recover. Patients at risk of falls or falls, what I would say is when we are assessing, we need to be systematic. Systematic means we look at right from the falls history all the way through to our objective assessment and paint a multifactorial picture of what is their challenge. Okay. And I've shared whatever it is, the flow chart, but again, in my other PowerPoint, there is that systematic way of doing it. In our intervention as well, we need to be targeted intervention and systematic. It is not enough for a patient to come to our clinic and all we say is exercise, exercise, exercise. And we give them every single exercise that comes to our mind. I think it's important we find exactly what is their problem and we find specific exercise in addition to general recommendations such as physical activity, specific exercise. So this is what we call the multi-component exercise that will help them. Is it balance they are struggling with? We talked about balance, dynamic and static. The fact that somebody is standing, that doesn't mean that they have a problem. They don't have a problem with balance. So we work on their balance, we work on their strength, we work on their coordination, we work on their functional tasks. Or it might be something beyond our control as physios. That's why the multifactorial intervention comes in. And we need to appreciate the role of other MDT team and refer them. Is it the vision that they need to look at? Or is it maybe some psychological factors that we need to reassure them and make sure that they are able to overcome their fear? And hopefully these are all the things that we'll look at. That is all I have for this morning. And I think we are bang on time. I will give the last 5 minutes because we are going to be flexibility also. Absolutely, yes. Flexibility. Flexibility is important. I agree with you. And I can talk about it more because like I said, somebody with tight ankle movement will fall because they cannot be able to, whereas what we call ankle strategy, they cannot be able to compensate for any disturbance or perturbations because of lack of flexibility in their ankle. So yes, flexibility is important. So I will stop here. The idea is we'll go for we go for 1 hour break and we'll come back by 1:30. Please, let's be here by 1:30. I will start my session by 1:30 on the dot. But also before we go on break, I'm going to stay here. If you have questions or you want to add anything, I'm more than happy for us to, you can put it in the chat box or you can unmute yourself and any question, I'm happy to answer it. But apart from that, if not, I will see you by 1:30 where we will look at research for impact. Thank you, Suleiman. Suleiman mentioned about the lot of cases of lack of flexibility, reduced base of support. Yes, all these are different components of the balance bit, but that's good that there is that awareness. Thank you so much. I will see you by 1 o'clock, 1:30 rather. But I will be around. You can, I think that's the end of the morning session.